Welcome at Medical Sciences Medicine by Naphtali Muhumuza. In this session, we want to discuss on the effect of acute inflammation. Previously, we discussed about acute inflammation, and we saw the processes that occur under acute inflammation, whereby in acute inflammation, we saw it is fast, but it takes a short duration, and we saw processes which we included the vascular events and the cellular events. Under vascular events, we looked at vasodilation, a moment of vasoconstriction, followed by vasodilation, which was making the blood flow, increase the blood flow to the surface of the blood vessels, leading to more supply of the blood cells. Then we looked at transmigration of the fluid due to increased vascular permeability, whereby the fluid was moving from the vessel into the extracellular matrix. Then under cellular event, we saw migration, rolling, and adhesion or attachment of the cells, leading to transmigration by diapedesis and chemotaxis movement or unidirectional movement towards the injured site, which ended by phagocytosis. Whereby phagocytosis, we saw recognition and attachment, then we saw engulfing and killing of the cell. So we want to know to see the effects of this acute inflammation, which is whereby when acute inflammation occurs, there are two major effects which occur. Either we can have resolution of the invading agent, or we can have healing by fibrosis. Healing by fibrosis, that is formation of scar formation to prevent the infection from spreading into other tissues. And this one can also result into formation of abscess. Formation of abscess. Like after surgery, we see sometimes abscesses, these ones contain pus. They contain pus, which is yellowish in form, and these ones can even form much infections. That is acute inflammation, and sometimes this one can persist and result into what we call chronic inflammation. It can be a precursor for chronic inflammation, and sometimes it can result into fistula formation. And fistula formation is whereby the tissues from different body compartments join together. You find blood vessels joining together with other organs. That is what we call fistula. So these are the fate of acute inflammation, whereby resolution, we see that what was triggering the acute inflammation, if it is a microorganism or a biological agent, it is killed and cleared. Or we can see if it was a physical agent or an immunological agent, it is removed by this acute inflammation, which we said it is. Acute inflammation is a protective role. It is protecting your body from these injurious agents. So that is what we call resolution. Then healing by fibrosis, we find that the resolution occurs, but we're leaving a scar, formation of the scar. And this scar is the one that prevents the spread of the causative agent. So it is also a protective law. And then formation of abscess, that is like pus, and then it can undergo that when it is persistent, when it takes long and it goes into days to months, it can result into chronic inflammation. And those persistent agents can be toxins. It can be toxins like silica. It can be autoimmune reactions or hypersensitivity reactions like rheumatoid arthritis. These ones can continue and join what we call chronic inflammation when the causative agent is persistent. Then fistula formation is that When this acute inflammation happens, it can join two different body compartments, leading to fistula. So this is the cause or the fate of acute inflammation, whereby the fate is that we can resolve the problem by killing the invading or removing the causative agent after acute inflammation. And we can see healing by fibrosis, we can see formation of abscess, fistula formation, or resulting into what we call chronic inflammation. Do not forget that the principal blood cell in acute inflammation is the neutrophils, and at a lesser extent, lymphocytes. And we saw the production of exudate. So at the end of this video, we shall see the difference between exudate and transudate. So the next thing we can talk about is morphological patterns. Morphological patterns of acute inflammation. And these morphological patterns of acute inflammation, they occur either, we call, number one, we can call serous inflammation. Serous inflammation. We shall see fibrinous inflammation. We can talk about supraspirative, or you can call it purulent inflammation. You can talk about catarrhal formation, catarrhal inflammation, and finally pseudo-membranous. And under catarrhal and serous inflammation, here we are seeing accumulation of clear watery fluid within the extracellular matrix. So the clear watery fluid, it just due to increased permeability of the blood vessels, it leaks out into the extracellular matrix, and this serous fluid is found in body cavity compartments, and this one can be in pericardium, can find it in pericardium, in pleural cavity, it can be found in the peritoneum. So, and this fluid sometimes it is rich in proteins. So we see the clear exudate, watery, just accumulating within. And sometimes this serous inflammation can also occur in the skin. For example, after being burnt by fire, we normally see blisters. It can appear in form of blisters, which are watery, clear. That is what we call serous inflammation. And then fibrinous inflammation, here we are going to see accumulation of the fibrinogen. Due to increased loss of the fluid to the extracellular matrix, fibrinogen accumulates within the extracellular fluid or matrix, and when it accumulates, it leads to formation of the fibrin, whereby fibrinogen is converted to fibrin, which always looks like a clot. And this fibrin that accumulates in the body cavities, and this one can either resolve by fibrosis. It can resolve by fibrosis, and this is what we call fibrinous inflammation. It occurs we can see an example as pericarditis. Pericarditis can be an example here. That this fluid accumulates in these body cavities and can result into what we call pericarditis, whereby it is just accumulation of fibrinogen which can be converted into fibrin, leading to inflammation within these body cavities. That is pericarditis, and it is caused by the increased vascular permeability. Increased vascular permeability, and this increased vascular permeability brings more of the fluid containing the fibrinogen. And then the third one is suppurative or purulent inflammation, which always comes with formation of pus. And this pus, which can be yellowish in color, contains pus cells or dead neutrophils. Those are dead cells. It contains necrotic tissue, and it contains much of the cells and the bacteria, dead bacteria. So these ones are seen in majorly infections. They are formed in infection caused by microorganisms, whereby, and this one you find it is looking like cheese and butter. Now fibrinous is the one that looks like bread and butter, or what we call cheese-like. This one looks like cheese, like appearance, but this one, it is a pus which can, and this purulent or suppurative or purulent is the one that results into abscesses or abscess formation. Results into abscess. Then catarrhal inflammation, this one occurs in the mucous membranes, like respiratory, in the respiratory system, in the lungs, whereby there is much mucus. So it is characterized by overproduction of mucus, like during viral infections, like rhinitis. Whenever you have rhinitis, that is what we call flu. We see much production of mucus from the respiratory system. So every time you are sneezing, you are producing much of the mucus. That is what we call catarrhal inflammation, whereby just the mucus is being produced in the presence of the viral infection. And then pseudomembranous, for it, the word pseudo means the false membrane. So there is a formation of a false membrane along the mucosa layers. That is the superficial epithelium. So we are going to see that under superficial epithelium or the mucosa, there is a formation of a false membrane. A false membrane, whereby the accumulation of the fluid causes this superficial epithelium to form a false membrane that covers the membrane or the epithelium of the body mucosa membranes. And this is what we call pseudomembranous inflammation. So in summary, we are seeing that these morphological patterns of acute inflammation include serous, whereby serous is, we have seen, is catalyzed by clear watery fluid occurring in the body cavities and under the skin in case of being burnt, whereby it forms the blisters and is rich in proteins. Then under fibrinous, we have seen the accumulation of fibrinogen due to increased extracellular fluid moving from blood vessels, and can lead to fibrin formation, and this one can resolve by fibrinolysis. And this one we have seen it can cause pericarditis, and it looks like butter and bread or cheese-like. That is the fibrinous. Then suppurative or purulent, that is the formation of the pus, which is always yellowish in color, and is seen in infections like bacterial infection, and it can result into formation of abscesses, whereby we see the fluid under this purulent has dead cells, necrotic tissues, and much of the bacteria. Then in catarrhal, we have seen it is in the mucous membrane, whereby it is characterized by excessive production of mucus. Like whenever we have flu during viral infection, what we give example as rhinitis. And then pseudomembranous is formation of the false membrane across the mucosa or the epithelial lining of the body. And after seeing the morphological patterns, we can end this video by looking at the differences between exudate and transudate. Exudate and transudate. So this side we are going to have exudate, and here we are going to have transudate. Transudate. And we normally see that this exudate, it is produced during inflammation, and this is non-inflammatory. It's non-inflammatory. This one occurs whenever the pressure, this is the blood vessel, we normally we have what we call hydrostatic pressure, which is forcing the fluid to move out. Hydrostatic pressure, then it contains plasma proteins, which exerts the oncotic pressure to keep the fluid within. So when hydrostatic pressure becomes greater than the oncotic pressure, we see the fluid escaping to extracellular matrix. And that's why we are calling, so it is majorly seen in raw albumin levels. So in other words, we are going to see that this one being non-inflammatory, at the same time, exudate is colored, and sometimes it has there is blood or hemorrhage during this process. But this one is clear, without blood. And this one contains blood cells, like white BCs, especially the neutrophils, and this one, no blood cells. You don't find blood cells in the transudate. And then another thing we can find is that this one has high content of proteins. Proteins are high, always greater than 3 grams per liter, grams per deciliter. Then this one is little or no proteins, because after all, it is caused by low protein levels. Then the specific gravity of exudate is always greater than 1.02, meaning the specific gravity is high, but here specific gravity is really always less than 1.02. And transudate or transudate. So these are some of the differences between exudate and transudate. Thank you so much for being with us. Please, I always remind you to subscribe if you haven't. Always hit the like button and always share your comments. So don't forget that in case you are asked in an exam to give differences between exudate and transudate, do not forget some of these points. I've given you, this occurs during inflammation, is colored, and contains sometimes blood, and this one has blood cells are prominent. That is number 3. Number 4, we have seen high content of protein, and number 5, we have talked about specific gravity. But this one is non-inflammatory, it is clear, no blood, and is majorly due to hypoalbumin levels or levels of albumin, whereby the hydrostatic pressure becomes greater than the oncotic pressure. And no blood cells are found there. Proteins are little or none, then the specific gravity is low. Thank you so much. In the next video, we shall look at chronic inflammation. Thank you so much.